Good evening, everybody. My name is Jenny Pearson. I'm an Education Officer for the PHN. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to elders past, present and emerging. I'm coming to you from Enewan land, which is Armidale on the Northern Tablelands. Tonight we have our Diabetes Alliance Masterclass number 3. Our presenter tonight is Dr. Judy Liu, who I'm sure many of you know very well. She's a staff specialist endocrinologist and general physician from Hunter New England Health. Don't forget to type in any of your questions in the question panel tonight. We have 2 diabetes educators with us tonight, Michelle, Chris and Gillian Dan, who are going to facilitate our Q&A session, which we will do at the end of the webinar. I think that's all you need from me. I have put up the learning outcomes in our evaluation. Some of them do relate to our previous masterclasses, so just answer them best you can. And I'll just hand over to Michelle and Gillian. Thanks, ladies.
Thank you, Jenny. Thank you so much, and welcome to the masterclass tonight, everybody. Before we hand you over to the amazing Dr. Liu, we just wanted to touch base with you all first and just remind you all that Diabetes Alliance is available for all GPs in the Hunter New England area, and we're always willing to receive any inquiries regarding that. We also have a new initiative happening at the moment. It's called Urgent Care, which allows the GP to be in touch with a credentialed diabetes educator, and have a discussion, and then the credentialed diabetes educator actually determines whether the patient and the GP can log in to have an interview with the specialist, the diabetes specialist, whether or not we can just solve some problems over the phone, or whether or not they need phone titration. So Jenny has kindly included that handout for everybody in the handout section of the webinar. And the phone number's 0436 276 161, and you'll always get an answer on the other end of the phone call, anything that's diabetes related. So I'm going to hand you over to Dr. Liu, and sit tight, and any questions Jill and I will answer if they're easy. Otherwise, at the end of the session, we'll flick them to Dr. Liu. Thank you. Enjoy the webinar.
Thanks everyone for joining tonight. I'd like to acknowledge the traditional owners as well. I'm actually coming to you from Kamilaroi country. We're up in Tamworth, and you can see we're in a hotel room. So hopefully this will go well. I think we've actually advertised for you Masterclass 2, which is the insulin prescribing module. So the numbering is slightly different on my slide, but tonight we're going to talk about insulin, the role of insulin for type 2 management, and how you might go about picking a regimen and a dosage. Hopefully everyone can see my slide. All right, so as I said, we'll talk about the indications, the different types of preparations. We'll talk about the role of GLP-1 and how it fits into our treatment algorithms now, and we'll delve more deeply into insulin, because GLP-1 is actually covered in Masterclass 1. We'll talk about the dietary advice given to patients, and also what to do about sick day and operative and fasting procedures, and some of the troubleshooting for patients. And because it's insulin, there's always a risk of hypoglycemia, so how you might go about educating patients on hypoglycemic management. And I have to say, this is probably the most common thing we get referred, patients are referred to us for, which is really just insulin initiation. And what we hope is, through the Alliance and through these masterclasses, that more and more GPs will feel comfortable to do this on their own. So it's always good to start with a common case-based scenario, and Mrs. DM is one of many sorts of patients that we get asked to see, and that you will see in your clinics all the time. So Mrs. DM is a 60-year-old non-smoker female who's had diabetes for over 15 years now, and as the old algorithm says, we did a stepwise process for her diabetes, which was as she started on lifestyle and metformin, slowly up titrated to the 2-gram maximal doses. When her HbA1c got to 8%, sulfonylurea was added, which is what the Australian guidelines tells us to do. And then when she got above 8% to 9%, a gliptin was added. She's already on an ACE inhibitor for her hypertension, and she's on statin therapy for her cholesterol. At this point in time, despite 15 years, she doesn't have any known micro nor macrovascular complications. But her HbA1c is creeping up and is now 9.5%. She's overweight, so you can see BMI is 35, and she's got central adiposity with waist circumference of 106 centimetres. And despite the ACE inhibitor, her blood pressure is still a little bit high. So what would be your next step? And I always prefer these as face-to-face presentations so we can actually have a good discussion about it. But I'm going to move on and show you what is the next step. So some of you will be aware that the pharmacological guidelines have changed internationally, and our one has been updated as well last year. But I find the Australian ones a little bit hard to follow the logic sometimes because it is driven a lot by economic considerations and PBS reimbursement. So I've taken the EASD, which is the European American Diabetes Consensus, and this has been updated based on recent scientific data. So this comes straight out of the 2022 Standard of Care. And so you can see that, you know, we no longer advise stepwise therapy. In fact, combination therapy is actually recommended for most type 2 diabetics. But depending on your risk factors, you may jump straight to insulin, or if they've got heart failure or kidney disease, or they've got basically an indicator of vascular disease elsewhere, so not known to be cardiac, but if they've got peripheral vascular disease or carotid stenosis, which is what they consider high risk indicators, then you might jump to a pharmaceutical therapy that actually targets those from a mortality benefit, not necessarily a glycemic benefit. And then there's always a need to reevaluate and reassess if therapy is working for glycemic targets, and if not, you up escalate. Australia actually fits in this green box at the end, which is considered cost and access. So Our Lady doesn't have a high risk indicator for a SGLT2 inhibitor or GLP-1, and because of the PBS picking up the cost is an issue, and so recommendations would be consider an insulin. She's already on sulfonylurea, or a thiazolidine dio, and then if above target, go back and have a look at what else you could modify. The truth, though, is that most of our patients will fit in this grey box, which is the need to minimise weight gain and promote weight loss. So what are the indications for therapy with type 2 diabetes? Well, clearly, if a patient presents with a diabetic emergency, so these are generally hypoglycemia, levels above 30 millimoles per litre, or in ketoacidosis, regardless of the level of glucose, these patients will require insulin therapy. Symptomatic hypoglycemia is an indicator for insulin therapy because insulin therapy only has a short half-life, which means you give insulin and it will last, depending on the preparation you use, 3 hours up to 3 days, which means it doesn't have to be permanent, but it works quickly. So you could start someone on insulin to treat their symptoms whilst the other treatment modalities get increased to their effect, and then you can always wean off insulin. But certainly weight loss or catabolic symptoms is a strong indicator that this person should be started on insulin therapy sooner rather than later. And in health pathways, we've actually put a BGL above 17, which is consistent with the guidelines. Steroid-induced hypoglycemia is another place where insulin therapy is probably the best thing to use, because again, people go on steroid therapy for an indication, and often the dose of the steroids will be weaned down as the indication improves. And that means that there is a short-term issue with hypoglycemia for most people, and it's a fluctuating levels, which means that oral therapies take too long to work. GLP-1s take a while to up-escalate, and so insulin therapy is used because, again, short half-life, you can get their diabetes under control, and you can wean off as quickly as the steroids are being weaned off. And we have preparations which will mimic the insulin resistance profile as well. If someone needs to go for surgery rather urgently, then again, you don't have time to wait for other therapies to become effective. So we use a lot of insulin for perioperative stabilization, particularly around the time of the surgery itself. Always think about starting insulin if you see someone and you're not sure that they are a type 2 diabetic. So you don't have to be sure that they are type 1. You just need to suspect that they are type 1. And again, you can send off the testing for LADAs and type 1, the antibody test, or you can measure their C-peptide. And in the meantime, you've protected them against DKA presentations if you commence insulin therapy. And if it becomes clear that they aren't a type 1, then again, you can wean off the insulin and switch to oral agents if indicated. And we also use insulin in pregnancy because we know it's safe, we know it doesn't cross the placenta, and again, we need very tight control and a lot of fine tuning. I won't go into pregnancy because that actually is MasterClass 3, and that deserves its own talk. The most common reason for starting insulin in type 2 diabetes, though, is actually for people who have done what Mrs. DM has done, which is they've had an increase in their oral anti-diabetic agents, and you're not achieving glycemic control. And at some point, most patients will require insulin therapy. But what about GLP-1s? Well, I've taken out exenatide because that's no longer available in Australia. And on the PBS, we have dulaglutide, which is Trulicity, and we have semaglutide, which is Ozempic. We've also got liraglutide, which is Victoza. But because liraglutide is not on the PBS, not many people are using it for diabetes indications. So what are the comparison between a GLP-1 that we've got in Australia and the insulins that's available? Well, looking at that algorithm, she's obese, her HbA1c was 9.5%, not quite above 10%, so maybe we could have gone with a GLP-1. The reason why 10% is picked is that we know that the mean HbA1c reduction for the weekly GLP-1 is somewhere between 1.5 to 1.8% at best. People will lose between 3 and 6.5 kilograms of weight loss, depending on whether they're taking dulaglutide or semaglutide. It's easier than insulin because it's only once a week. Timing of the day is not so important. And it's easier to initiate because there's only a couple of doses that they need to think about. And the devices, the Ozempic device is basically an insulin pen, but there's only one number that they need to dial up to, or two numbers at most on the titrate, on the initial starting dose. It's got a low risk of hypoglycemia, which is very attractive, particularly if patients are at higher risk of adverse outcomes. It is durable, but certainly not for decades, and that's because its glucose lowering effect does require functioning beta cells, and as we get older, we do lose beta cells, so they atrophy as well as most other things in our body, so the ability to produce the insulin declines, and at some point people will need to go onto insulin. The main problems with the GLP-1 is the GI side effect. So I think most people now would have had some familiarity with having started GLP-1s in their patients. And as you know, the most common complaint will be the nausea or the vomiting. And after that, the diarrhea. For some people, it's the constipation. Most people will tolerate the constipation, but the nausea is what people tend to end up ceasing therapy for. We also know that with only a 1.5% reduction, if you're above 10%, you're not going to get to 7% on a GLP-1 unless you're a super responder. And there are some people who are, because we are giving you the average response, but you shouldn't expect them to be a super responder. It's a great thing if they are, but the expectation is that the majority will not achieve 7%. It's also not been studied in end-stage renal failure. So the GFR has come down to 15 with dulaglutide and 30 for semaglutide, although when you think about the physiology, there shouldn't be any difference between the cutoff for the eGFR, but certainly no studies in end-stage kidney disease for its use. And so, again, not safe if you've got someone with end-stage kidney disease. Insulin, we've had for 100 years. So for those of you who've been keeping up to date, you know this has been an exciting last year and this year for the 100th anniversary of insulin. We know it's very effective at reducing blood sugar levels, and it's very rapid in its onset. You can get whatever HbA1c reduction you require if you use a large enough dose, but it does cause weight gain because it does allow the energy to be stored. So most people on average will gain 2 to 5 kilos in the first year of commencement of insulin, after which they should plateau. The difficulty with insulin is the fact that there are so many different names, and it gets all very confusing trying to remember which one does what, and different combinations and where you can combine them. So hopefully we'll address some of that tonight so that it won't be so confusing. If the insulin dose does not match the patient's requirement at the time, then there is a risk of hypoglycemia. And this can be quite scary for patients, and also means that we need to spend a little bit more time educating patients on the symptoms of hypoglycemia as well as the management response. And a lot of people who drive are very fearful of starting insulin, that they might lose their driver's license if they have hypoglycemia. But again, we'll talk about dosing to avoid this. And most patients can avoid it with the right education. It is quite durable, and it is effective no matter which stage of diabetes you started at. In modern type 2 diabetes management now, we now recognise that it's not actually a or question. And in fact, the scientific data is that most patients with type 2 diabetes would benefit from both if their glycemic control can't be achieved with a GLP-1 on its own, and I'll show you a bit of data for that. So the American Diabetes Association, which is kind of the international body, even though their name says American, they put out a guideline every year which goes through standard of cares for this year, and this is from this year's guideline. So you can see that, you know, chapter 9 is actually pharmaceutical therapy, and recommendation number 7 was that we should consider insulin early if they've got those conditions we talked about, the weight loss, the symptomatic hypoglycemia, A1C above 86 or 10%, and because they're American, it's rounded up to 300 milligrams per deciliter, which works out at 16.7 millimoles per litre. But somewhere in the vicinity of 15 to 17 is when you're going to introduce insulin. Recommendation number 10 is that most people with type 2 diabetes, a GLP-1 is preferred when possible. And you'll notice it's when possible because, again, if you're not going to achieve target with the GLP-1, then it can't be used as sole therapy. But you can see that recommendation comes with A-grade evidence. It can also be used in combination. So insulin and GLP-1 is recommended together because there is now good evidence that the durability of treatment and the efficacy is better in combination than with one or the other. And so the companies are now starting to make basal insulin with GLP-1 mixed together in a single injection. They are not available in Australia yet, but I imagine we will have those over the next few years. So certainly recommendation 11 is why the PBS now also allows GLP-1s with insulin. So as I said, I'm not going to spend too much time talking about GLP-1s, but I'll take questions at the end if people want to ask them, because I really want to talk about insulin, which is a little bit more complicated to get your head around. So as I said, it's 100 years since we discovered insulin, and we know quite a fair bit about it. I put this slide up because this is worth keeping in mind, which is what does our body do when it makes insulin? So we all know that the pancreas produces insulin. And in fact, the pancreas is pulsatile in its insulin production. So it gives a little bit of insulin every 3 to 6 minutes based on the glucose level. And then that insulin goes through the portal system, and most of it works on the liver. And its role in the liver is basically to determine whether the liver is going to be making glucose, so breaking down glycogen or making glucose from scratch with triglycerides, with gluconeogenesis, or whether it's storing the glucose. So the liver plays a key role in type 2 diabetes pathogenesis. The insulin that isn't taken up by the liver then can pass through into the systemic circulation and target tissue cells. And that's what we tend to think of when we talk about insulin pharmacotherapy, which is, you know, the cells are taking up the glucose into the muscle for glycogen, or they're taking up as fat in the adipocyte, or they're being utilized by the cell for metabolism to make ATP. The other thing that we know about insulin physiologically, that in our islets, insulin comes as a range of different shapes and sizes. So we produce insulin as a monomer, so a single molecule, but insulin likes to combine with another monomer to form dimers, and it does that through electrostatic charges. The dimers tend to combine together to form hexamers, and that makes it an even larger, almost a macromolecule, although they are still individual molecules, but they are sort of connected to each other by their electrostatic charge. And if you introduce zinc into it, which our islet cells have, which is why we've got zinc transporters, you can stabilize the insulin as a hexamer. And there are two types of hexamers, which you don't need to remember, except to know that you can make the hexamer even more stable by altering the configuration or the rotation of the insulin molecule itself. And that means that when it's in a big hexamer form, it's very stable and it doesn't degrade, it doesn't break down. And that's how it sort of lives in our islets until it's released into the bloodstream, where it goes back in reverse, which is that the hexamers then dissociates into the dimers, into the monomers, and the monomers can go on and activate the insulin receptor. And that's worth remembering, because when we talk about insulin pharmacotherapy, what the companies have done is modify the insulin molecules in very minor ways, but in ways which makes it behave as a more stable form, such as a hexamer, or a less stable form, which is the monomers. And that's all we've done to make it rapid or less rapid. So as I said, it's the 100th anniversary, and I'm giving this talk almost 100 years and a month to the day, after the first pharmacotherapy use of insulin. And that was only, 3 months after the actual discovery. So probably the most rapid advancement. And we have advanced, we've made more advances since that time. And I'll talk very quickly about some of them, because the more modern insulin, we're not using some of the old technology, but some of the old insulins are still with us. So insulin pharmacotherapy is quite different to what our body does. So one, it's not made in our pancreas, it's not going through the portal vein, and it's not going straight to the liver. What we do instead is that we inject the insulin into the subcutaneous space. And then we wait for the insulin to dissociate from that space and enter into the capillaries in that subcutaneous tissue, and the capillaries are then going to carry the insulin around the body and get the effect we want. And so you can see straight away that there are things that are going to impact my insulin getting into the bloodstream and actually activating the insulin receptors to bring down the glucose in the bloodstream, which is what we generally want to do. So if you inject into an area with poor blood flow or where there's a lot of scarred tissue, then that insulin is not going to get into the bloodstream. And that's going to affect the efficacy of your insulin. The dose, because there is no gap in your body waiting for you to fill it up with some insulin solution. When you inject a dose of insulin, you're actually forcing the fluid, and that compresses the cells around it. So the more you inject in one spot, the bigger the compressive factors, and those little capillaries that I want to try to get the insulin across to, they get compressed as well. But also the fat cells that live around the subcutaneous space, if it sees insulin all the time, so people are not rotating their injection site, then the fat cell is going to respond to the insulin that's there, and they're going to take up the glucose in their surrounding tissue, and so you get hypertrophy of fat cells, and that's been clearly demonstrated under microscopy. But also, if you even just ask patients who've been on insulin a long time, you can often see the lipohypertrophy without them even taking their shirt off if they're not rotating their sites. The injection site is important because, particularly for obese patients, edema can also mean that there is a less availability of blood flow and uptake of insulin, but also the pH of the tissue site affects whether or not the insulin is in a hexamer or in a monomer formation. And then, of course, we have modified the human insulin to behave in a way that allows us to get the effect we want. And that's where we've changed their name and given them different, and we're giving them different brand names. So as you can see, insulin pharmacotherapy is not just about the dose and the type of insulin you inject, but you do need to think about the injection technique in the injection site. So this is where having a diabetes educator or having a nurse who's been educated on insulin is very helpful. And so in part of our Alliance program, for those of you who participated, you'll realise that we spend a lot of time educating patients and the nurses on how you check the injection technique in the injection site to make sure that it's actually optimised beyond just worrying about is the dose correct. So we recommend the injection in the subcutaneous tissue because that's what all the studies are done for, okay? And that's where the capillaries are. If you inject it in the skin, intradermally, then they're not the availability of the vascular capillaries, so your insulin won't work very well. And if you inject it too deep and you inject it into muscle, then there's too much vascular supply and the insulin gets absorbed super quick. And that runs the risk of an intramuscular injection. And again, you know, people expect their insulin to work a certain way, so you want subcutaneous fat. So over the last 10 years, we've realized that the previous recommendation for needle length is too long for most people. And even in obese people, you do not need a needle much longer than a 4 or 5 millimeter needle. So the recommended needle length when you talk about insulin with your patient is 4 to 6 millimeters. And if they're using an 8 millimeter or a 12.7 millimeter needle, which is no longer made actually because of the studies, the aim would be to try to get them to reduce to a 4 to 6. Now, some people, injection technique is not so great, and so they don't hold it as perpendicular, and they may complain about stinging, which is usually to do with an intradermal injection, or if they're using Lantus or Glargine, which is Semglee, the other Opticillin and Semglee now. That's slightly acidic, and that can cause a bit more stinging when it's just underneath the skin layer. So that's why I occasionally recommend a 5 or 6 millimeter needle. And the other benefit of the 5 and the 6 millimeter needle is that the gauge is slightly larger, which means if you've got someone on a large dose of insulin, it's a little bit easier to press the button because the gauge is a little bit wider than a 4 millimeter. But for the majority of people, a 4 millimeter needle will work well and runs a low risk of an intramuscular injection, even in obese people. The targets that we're aiming for, we recommend you individualize. So again, this is adding to some of the intricacies, but the general rule is it depends on how long you think your patient's got to live, how worried you are that they're going to develop a complication from their diabetes, particularly microvascular complications, and how averse you are to causing hypoglycemia for this particular person. Young people will tolerate hypoglycemia quite well because they've got good hearts, good brains, and good adrenergic symptoms to give them warnings. Whereas older people, you obviously want to be a bit more cautious because their heart's not so good, their brain's not so good, and they may not have as good an adrenergic response, so their ability to sense a hypo might be a bit lower. But in general, if we're going to avoid microvascular complications over the next 10 years, so again, if you've got someone whose prognosis is less than that, you may not be too worried about it, but if they're going to live more than 10 years and you don't want them getting retinopathy or neuropathy, then the target is 5 to 7 fasting and no more than 10 after a meal, with an average, with an aim for a HbA1c around 6 to 7%. And that again is based on UK PDS data. If you are worried about hypoglycemia and you don't think that they're going to live long enough to develop the microvascular complications, then you can be a bit broader with your targets, which is 6 to 12 or even 6 to 15 if they've got a very short prognosis. And that's really just to avoid the symptomatic hypoglycemia and the immune paresis, which predisposes them to more infections. But it doesn't mean that we let them run with hypoglycemia and polyuria and polydipsia, because, as I said, it's not a painful injection. In fact, it's pretty painless to do insulin injections, and it's easily adjustable to the target you want, particularly if they've got a steadier lifestyle or steadier diet. We're going to talk about the older insulins, and again, I suspect that these will slowly fade away from practice over the next 5 to 10 years, but they're still around now and there's still an option available to you. We don't use bovine and porcine insulins anymore. We haven't had that for over 10 years in Australia. We still do have recombinant human insulin, and that's basically unmodified, straightforward human insulin, similar to what your pancreas would make. And that means it does tend to form hexamers a little bit more. We call those insulins Act Rapid or Humulin R, which are the two generic version. If you read the fine print, it's actually recombinant human insulin. If you throw protamine, which is a big molecule, into the mixture, then the insulin monomers tend to attach itself to protamine, and therefore that's why that's called protophane. But protophane is basically human insulin with protamine in the mix. Humulin NPH is just the Lilly version of protophane, and it's again available as a vial. And you can put protamine with any insulin you like, and that will prolong the action time of protamine. And so the pre-mixed insulin, whether they are Novamix or Mixtard, are basically protamine thrown in with an insulin, either human insulin or an insulin analog, and you can make whatever mix you like depending on how much protamine you throw in. So that's why you can get a 30-70 mix or a 50-50 mix or a Humalog mix 25. Because these are pre-made in the factory, you don't get a choice in the combination, and the combination assumes that the protamine is uniformly distributed in the bile, and that's why these older insulin can be a bit problematic if people aren't mixing their insulin well. But they give us a pretty good profile, and we still use them up to now. So we know that we can get good outcomes using human insulin. And in fact, there is no study to show that analog insulin is better than Act Rapid for glycemic control, although hypoglycemia is less with the analog. So that's the reason people moved away from it, not because the control is better, but because the hypoglycemia is a bit less. So when you mix it with protamine, you can drag the action time out to about 12 hours from a 4 to 6 hour window, which is what you'll get with Act Rapid straight up. And as I said, if you mix the two, then you'll get a small peak at around the 2 to 3 hour mark, and then you get that long drawn out phase. The problem, of course, is that the long drawn out phase is still quite high, because you can see that even at 9 hours, it's still much higher than at 15 hours. And if that's occurring in the middle of the night and you're not eating, hypoglycemia can occur. So that's why they've kind of fallen out of favor because of nocturnal hypoglycemia. Because if you give Mixtard at dinner time, then at 2 to 3 o'clock, you'll still have a lot of insulin in the system at 2 to 3 a.m. when you may not be eating. So matching the food to the insulin dosing is a bit trickier. And that's why with the older insulins, we used to tell patients to have supper, which of course you may not want to do if your patient is obese. But that's one of the ways we used to get around the nocturnal hypoglycemia. Obviously, we don't want people to eat if they're already obese, so we're trying to move away from those regimens for those people. So in an attempt to try to mimic the glucose excursions from when you eat your food, which is very rapid, and if you've ever treated hypoglycemia, you know how rapid glucose gets into the system. So we can, from mouth to blood, it can get in there within a few minutes. So we wanted a faster onset. So they've modified the insulin molecule so that now instead of the hexamers that it has a tendency to form, it generally stays as a monomer. And that's just by altering a few proteins in the molecule itself. With the analogues, of which we have 3 in Australia, we have Aspart, Lispro, and Glulisine. They go by the brand names NovaRapid, Humalog, and Apidra. It's worth noting that the brands are now off patent, which means that the generic ones are going to come through and they'll have their own brand name. But basically, these rapid insulin analogues are basically half the times of the human unmodified one under the skin, which means that they get into the bloodstream a little bit faster because they tend to just be in monomers. They don't tend to form hexamers. They peak a bit earlier, so 1 to 2 hours, and they're pretty much out of our system within that 3-hour time frame for a standard a dose. And that means that there's less risk of people having insulin late in the evening or late in the day when they're not eating. And again, you could throw protamine into your analog mix, and then you can call it Novamix or Humalog mix. And they've used the same ratios pretty much as the older Mixtard mixes, which is the 30, 70, 50, 50 mixes. But because of the protamine, the pre-mixed ones, they all look cloudy, and sometimes we call them cloudy insulins. Again, you need to get the patients to mix them well and uniformly, which takes time, and that's something most people are a bit short of, and so people can get a bit lazy and start to cut corners. So it's always worth reviewing the technique of your patient's injection once a year or so, just to make sure they haven't got into lazy or bad habits with mixing the insulin. And it takes about 20 seconds to mix the insulin well, a bit like hand washing. So we've all learned how lazy we got, and then we've all learned how to wash our hands better in the last 2 years. Patients can get a bit lazy with the mixing, but a reminder usually gets them back on track. So again, the same sort of peaks that you'll see, you'll get that rapid peak. So you can see much shorter with the insulin analogs, and then the protamine just drags out the effect, because it basically means that the insulin cannot diffuse across because it's stuck to the protamine and it has to come off the protamine first. We can modify the insulin molecule so that now, instead of being in monomer forms, they tend to form the hexamers, and that means it slows down the absorption time. So these insulins are designed to basically stay under the skin for longer. That obviously is not the case if you inject them into a muscle or straight into bloodstream. But under the skin, they won't absorb across the capillary membrane because they're nice big hexamers and they need to dissociate. And the modifications are slightly different depending on the type of insulin, but basically the idea is so that instead of having to inject your insulin 4 times a day like you would need to do, and that's the first use of insulin back in the 1920s, people had to inject insulin 4 to 6 times a day to get a full day's coverage, because obviously that was only bovine insulin at that stage. Now people could do once a day injection and it will just slowly absorb across that 24 hours. So the peak is delayed, takes 2 hours to even detect it in the bloodstream, and it peaks around at 6 to 8 hours. You don't have to worry about that as a rule, because once people have been on it, the tail overlaps and so it looks relatively flat. But if you're starting someone on your glargine insulin, then maybe for the first 2 days, they may not have reached equilibrium, but after that they do. You can see that offset is between 20 to 24, and that again depends on the person's skin dynamics or subcutaneous tissue dynamics, as well as their dose. And so some people do need twice a day injection. Some people will get away with a once a day. And that's a big improvement over Protophane, which was twice a day with that peak in the nighttime that people had to worry about. This removed that peak at night, so the hypoglycemia risk was lower. Detamir is worth noting. It's not approved for type 2 diabetes in Australia, but that doesn't mean that it doesn't work. And it's just a small side point that most of us has forgotten now. But Detamir is designed so that not only does it take a while to absorb from the subcutaneous base into blood, but once it gets into blood, it binds to albumin. So the albumin acts like protamine. And so again, Detamir can prolong its half-life because in the bloodstream, it's not freely available instantaneously to the insulin receptor. And that's worth remembering because we're going to talk about Degludec next. And Degludec is made by the same company that makes Detamir, but they've further refined their basal insulin. So this one has made things a little bit harder for everyone to understand. But the idea is that basal insulin doses shouldn't change much on a day-to-day basis, because on a day-to-day basis, we tend to maintain our weight about the same. We tend to run the same body temperature and we tend to have roughly the same number of heartbeats and respirations, give or take, a few percentage points, which means that our energy requirements from insulin shouldn't change. And so the idea is, well, what if I can make a basal insulin that I don't even have to inject once a day, but I can inject it maybe once a week? And that's kind of where Degludec started. It doesn't quite last a week, but it does last several days. And it's completely different to the way we've thought about and taught insulin in the past. So again, you can see that the monomer, the Degludec monomer, is basically an insulin monomer, and then it's got this little tail that hangs off the end, and that's a fatty acid tail called a myristic tail. It's the same tail that Detamir has, and that allows it to bind to albumin. So you can see on that little cartoon on the side, What happens with degludec is that it's modified. So now not only does it form hexamers, but the hexamers tend to form chains. So you get these sort of chains underneath the skin. And there's a zinc molecule in it that stabilizes the hexamer, and there's a phenol molecule that stabilizes it, and then the myristic tails stabilize the chains together. And that means it's very slow to dissociate and get into the bloodstream. And even when it's in the bloodstream, it also weakly binds to albumin, and that also prolongs its activity. And that's really good if you want to get away with less injections or a very flat profile, because there won't be much of a peak with degludec. So if in the bottle, in the vial, it doesn't form the chains because that's partly to do with the pH interaction. But as soon as it's injected under the skin, you can see these chains, and you can see them under the microscope. They're more like a branching pattern of insulin, and so very, very slow dissociation time. Of course, the degludec didn't quite make it a week, but it made it about 3 days, which meant that you could get away with an injection every 3 days. The problem was that in the early phase trial, people aren't very good about remembering something every 3rd day. And because it's got a very flat profile, it turns out that actually people are more adherent if it's done as a daily injection. And that's how we use degludec now. So this is, again, worth remembering, because I think Ryzodeg is a very useful insulin for most type 2 diabetics, and is quite a forgiving insulin. So unlike the Novamixes with the protamine, where you have to give them roughly 12 hours apart because of the peak and the ebb, with degludec, the dosing of your once a day or twice a day dose is not so important. But what you'll see is that when you inject degludec, half of it is still under the skin in the next 24 hours. So it's got a half-life under the skin of over 24 hours, and then only half of it's absorbed at any time. So it takes you about 5 to 6 days to get to a steady state from a steady dose. So if I'm going to start someone on Ryzodeg, and we'll go back to Ryzodeg because Ryzodeg is not pure degludec, but the degludec component of that, you can see if you do 10 units every day, the first day you only get 5 units in the bloodstream. And that means that patients, if you don't warn them, they'll say, this new insulin doesn't work. It doesn't work as well as my Opticillin or my Toujeo. So I tend to tell people, don't worry about the first 3 or 4 days, and you only adjust a dose once a week, because adjusting it on a daily basis will make you have to do very complicated math to work out what is actually going into the system. And again, this is in the perfect scenario of a good injection technique, a healthy tissue, a good blood supply. But you can see that the degradation, well, just like degradation, the absorption is about 50% each time. So the first day you inject 10 units, 5 units in the blood, 5 units in the skin. The next day you do 10 units, but you still got 5 units from yesterday. So actually there's 15 units under the skin, of which 7.5 is going to get across to the bloodstream, and the other 7.5 is going to sit under the skin. On the third day you do 10 units, but you've got 7.5 from the 2 preceding days, and so actually the subcut depot is 17.5 units, and so you've got about 9 units into the bloodstream. And similarly, when you stop degludec, or if you decide to switch them back to Opticillin or Toujeo, you've got to remember that you've got to go backwards, which means you've got to slowly build up the dose, because you could overdose them if you did a straight swap of dosing. But basically, by the end of the equilibrium, what the bloodstream sees is what you inject, but what's under the skin is about twice as much, because 50% is in reserve. I hope that makes sense. Now, unfortunately, in Australia, we weren't given degludec in its pure form. We were given Ryzodeg. So Ryzodeg is 70% degludec and 30% aspart. And so you got 30% which are pure monomers, they're going to get in quickly like the Nova Rapid does, and then the other 70% is that slow acting part. But that's why it's got the flexibility for mealtime, because I know that the aspart part is the part that deals with the food, and my degludec is going to take 3 days, and so it doesn't really matter if I'm a few hours early or late. And so you could do degludec once a day or twice a day or even 3 times a day. The problem with 3 times a day is that you may end up with more basal insulin than you want because the ratio is not quite right. But you know, twice a day for most people works out quite well. And unlike the Nova Mix, where you have to have breakfast at 8 and dinner at 8 p.m., it doesn't matter what time their meals are, as long as they do it with the meals that you want to cover with the aspart. So that's how Ryzodeg works. And for some people, you know, we give them once a day and we just ignore the prandial rises with the other 2 meals, or we ask them to have less carbohydrates with the 2 meals that we aren't giving any aspart insulin for, to prevent that prandial rise. And it works quite well, and pretty much as well as Nova Mix 30 without the need for mixing. So when you look at Ryzodeg, there's no protamine, it's not cloudy. They don't need to do the mixing, which means I know that there's a 30–70% each time, unlike the protaminized insulin. And that's why modern insulin therapy is moving away from protamine. But again, complicated, because if your patient is a tendency to tweak their insulin, then the degludec component gets quite confusing to try to work out what's actually going on, both under the skin and in the bloodstream. So we've talked about the premixed insulin, which is basically an attempt to try to reduce the number of injections. So with each injection, I'm actually injecting 2 formulations of insulin to get the effect that I want. It's quite good for people who have pretty fixed, stable life patterns and pretty stable meal patterns that are roughly 12 hours apart if they're on the Nova Mix or the Mixtard. Not necessary if they're on the Ryzodeg, but they still need pretty stable carbohydrate intake for that fixed component of rapid insulin. As I said, mixing is really important. So they can't just shake it side by side. They actually have to invert the pen and they have to roll. So we talk about rocking and rolling. And if you do Alliance, we'll take you through exactly what mixing involves. And we have to be careful of stacking because that protamine component has a peak and we don't want to stack peaks on peaks. So you need to think about that, which is why with the advent of flatter basal insulin, I think more people have moved on to a basal with a 1 or twice a day analog that is not mixed together. And that's basal-bolus therapy. And that's kind of what we teach type 1 diabetics, but a lot of young, I shouldn't say young, a lot of type 2 diabetic patients can also grasp this concept, and they often prefer it because they feel like they've got more control and they're more in charge and they can see what the insulin does and which one they need to adjust. So it's much more suitable for flexible lifestyle, and pretty much everyone has a flexible lifestyle because we all like to eat different meals and variety of carbs and choices. But it does need at least 4 injections then if you're having 3 meals a day. Again, like I said, you know, patients can adjust, so they could learn to have less carbs with certain meals and get away with less injections, but for good control and for the standard 3 meals a day eater, it's 4 injections a day. There are now lots of apps and meters that are able to assist patients to carb count, so work out how much carb and therefore can adjust the quick acting insulin to fit the food, and that again gives us better glucose control. That's an extra step, but it's certainly a lot easier than 10 years ago or pre-internet days when people had to memorize or carry books. And the ultimate in flexibility, of course, is pump therapy. I'm not going to talk about pump therapy in detail in this masterclass because it's access to pump therapy for type 2 diabetics that are the issue. So basically, a pump delivers a rapid insulin. So that could be your Humalog or your Nova Rapid. And again, they're just monomers, so they get across into the capillaries very quickly. There is no depot sitting under the skin, unlike when you do an injection. And the pumps are delivering a little tiny micro aliquot every 5 minutes of insulin. So you can imagine there's not a lot of compression because there's not much insulin in each of these tiny microliters of delivery. And you could adjust, and now that we've got CGM, we've got these what we call closed loop systems where the CGM talks to the pumps, tells the pump what the sugar's doing, and the pump can adjust the insulin delivery dependent upon what the glucose profile is doing. So CGMs read every 5 minutes, pump deliver every 5 minutes, so they work well together. But as I said, the biggest barrier for people is cost. For some people, I mention it to them if I think that it will really improve their control, and I think it's worth their investment. Insurance companies will generally not reimburse for a patient with type 2 diabetes, but for some patients who've got gastroparesis, for example, where it's very hard to predict what the glucose is going to be when they eat, because that depends on whether their gut is going to empty the food out or whether it's going to sit in their stomach for a while. That can be quite problematic, and that's where a pump really comes into its own. And then obviously for our type 1s, they are reimbursed by most health insurance premiums if you've got silver or above. But there are the odd patients where pump therapy may be an option for them. But again, we can achieve quite good control with MDI for majority of patients, so this is not needed at considerable cost for most. A quick slide about insulin devices. We'll come back to dosing. I haven't forgotten that that's what we're talking about. I just wanted to introduce the idea of thinking about what insulin is doing under the skin and in your blood when you pick a dose. But insulin basically comes in pens, syringes, and these inulate devices. In Australia, there is really no benefit of using an insulin syringe. In other parts of the world, that's still the cheapest way to deliver insulin. And the insulin syringe, for those of you who've been around long enough or have seen them, they're basically a 1 ml syringe because insulin is standardized to 100 units per ml. That's the what we call a U100 insulin, and most of our insulins are U100, and so they work fine in an insulin syringe. The insulin syringes, going along with the needle recommendations, have now got shorter needles, so you can get a 5 millimeter insulin syringe rather than the old 12.7 millimeter insulin syringes. But because there's no cost benefit for patients in Australia to be on syringes, most patients will be on a pen. As you know, there are disposable pens, which is what most people prescribe. So depending on your company, you're going to write Solid Star or Quick Pen or Flex Touch or something like that. And they are basically preloaded, calibrated devices so that patients don't have to draw things up. They can just dial their dose, put on their little needle and inject. There are reusable reusable pens, and that's helpful if you've got someone who's very sensitive to insulin, because the pre-loaded ones, the disposable ones, they go in 1 unit dosing. So if you wanted to give someone who's very sensitive and they wanted to use half a unit, then there are reusable devices from all the companies which will deliver half dose. Toujeo is a U300 insulin. So that means that it's got 3 times as much insulin per meal. So it's 300 units per meal. And for that reason, Toujeo does not come in anything but its own pen. And you shouldn't draw it up into an insulin syringe because you'll end up giving yourself 3 times the dose. So the non-U100 insulins always comes in their own devices that are not adjustable. The Insulet device is kind of old, so it's a clock device, and so again you can see that there's a cartridge of insulin on the side. These are preloaded, and you can dial up the insulin on a clock face, so rather than a dial at the end. They're helpful for people with limited you've got arthritis and limited dexterity, because the dial is a lot larger. And in fact, I've had patients who've got finger amputations, and so they can't dial up the little dial at the end of the pen, and they could dial this using just a couple of knuckles. And it's got a very big button, which again can be helpful. It also makes a loud click. All the pens make clicking sounds because retinopathy is so common, so companies know that it needs to be audible. But the bigger button can also be helpful for the sight impaired. The problem with the Insulet is that it only takes older insulin, so it's only got, your only options are Protophane and Mixtard in the Insulet devices. So for the majority, like I said, we prescribe a pen or a pen-filled cartridge, which they can then load into a pen. Okay, so we've covered basically the options for types of insulin, the injection sites and techniques, and why don't we use insulin more frequently? So this, I guess, is where things get a bit trickier. So as I said, it's problematic because most people are fearful of needles. All the needles they've had to now have taught them that it's painful, it hurts, and the idea of putting something sharp into themselves, it goes against the natural instinct to avoid sharp objects. People worry about hypoglycemia, particularly if they get hypoglycemia with their first dose. They may never be able to be convinced because it's very frightening. Hypoglycemia results in a massive adrenaline surge, which is your fight or flight response, and it makes people feel like they're going to die. It gives them chest pains, palpitations, they sweat, they feel like the world's going to end because that's the warning sign that you need to do something. And if that is an experience they have, then they get very frightful of ever having that again. And of course, people worry because if they've noticed or they've heard that insulin causes weight gain, or we're worried because we're worried about weight gain. But I'm hopefully going to show you some data to say, look, I don't think we should worry as much about weight gain if we are getting our insulin physiology correct. So there's not many trials of insulin in pre-diabetics, and this is one of the largest trials. And you can see how old this is. This was a couple of years after glargine was available, which is Lantus, and this is the Origin trial. And basically, we know that early glucose control has a legacy effect and actually prevents complications even after the control is relaxed. So we know from the UK PDS and the DCCT that even after the intensive phase, when people got back to being baseline with each other, that there is protection from complications. So Origin was designed to look at, well, what about giving people insulin early in the course and giving the pancreas a rest, because there's some concepts of if the pancreas doesn't have to work as hard, maybe it will be more durable. So you see, large study, they picked people with high risk of cardiovascular disease and who were pre-diabetic, and they gave them basically glargine or the standard of care at that time, which would be oral hypoglycemic therapy or metformin lifestyle. You can see that they did not have high control, and the dose of insulin that they ended up needing was very low. And in fact, if you look at data for type 1 diabetic patients, this is about physiological replacement. So only 0.3 to 0.4 units per kilo per day. The weight gain was 1.6 kilograms, but people did not keep gaining weight on top, ongoing. That was the weight gain, and then they plateaued. They definitely had more hypoglycemia than the group that did not get insulin, but it's not a large number. It's 1 in 100 person years, which is less than what the UK PDS had in the late 80s, early 90s. And they did show that the group that got the glargine insulin were less likely to progress to overt diabetes over that 6-year period. But they were interested in protection from cardiovascular, so macrovascular complications, which they couldn't show in that 6 years. But it was also used because around that time, people may remember there was a bit of a scare about whether or not glargine caused more cancers or not, to show that they didn't get cancer. So we know it's safe, or safe-ish, with a low risk of hypoglycemia in small doses, even in the early phases. And that kind of makes sense because it's basically like most hormones, you just down-regulate your own production. So, you know, if you're euthyroid and you decided to take thyroxine, your endogenous thyroid hormone would down-regulate. The same with insulin. If I injected insulin, then my pancreas doesn't need to do it. And so the physiological replacement is not a big problem, even early in disease. But what is physiological replacement? And that is a much harder thing to define because a lot of what we know about diabetes come from type 1 diabetics. And that's helpful because they don't make insulin. So we can work out how much insulin we need to keep them healthy and alive. And we've had 100 years to do that. Type 2 is a very different disease. And in fact, type 2 is probably a range of diseases and not a single entity at all. And trying to work out the dose of what type 2s need is a little bit trickier. But you can see that even for type 2s, 1 unit per kilo per day, about 90% of people are going to achieve target. If you're needing more than that, then there is something odd. You're in a very strange pathological state. And that's helpful because over time, we've gotten more comfortable with insulin and insulin dosing and managing hypoglycemia. And we've got a lot more people with diabetes driven by obesity. So the question is, what is the optimal insulin dose? So do I give them if I don't give them enough insulin, then they're going to remain hypoglycemic, which defeats the point of glycemic control and prevention of complications. But if I give them too much insulin, because they haven't addressed their dietary intake of glucose. So basically what I'm doing now is giving insulin to bring down excess calories. I'm going to store that. And that may drive more weight gain, more hunger. The larger doses of insulin runs the risk of an imbalance if they decide not to eat that amount of carbohydrate. And we see this in hospital quite frequently. Patients who have very large doses in the community and they come to hospital and suddenly their carb quantity is restricted or they're nil by mouth, and we are, madly winding back the amount of insulin. And as time goes on, there is concerns that we're driving complications of its own, of insulin excess, which is we've seen an explosion of fatty liver disease and intracardiac fat-causing atrial fibrillation with over-insulinization. So the aim is to find the sweet spot, which is, enough so that I'm replacing what their body can't make and getting glycemic control, but not so much that I'm driving this excess caloric storage. And for diabetes type 2, that can be a bit tricky because insulin resistance varies between people and it varies day to day. But basically, if you're needing more than a unit per kilo, because that's the scientific definition of insulin resistance, then you're probably getting to physiological replacement, and anything extra is probably just excess caloric stores, or you haven't got type 2 and you've got something very unusual. So you've got an insulin receptor defect, or you've got a strange lipoatrophic condition or something along those lines, but you're not a standard type 2. So the guidelines actually have this now because often we have a tendency to chase glucose numbers. So we have a glucose-centric approach to diabetes, which is we think your glucose is high. We know that insulin will bring the sugar down. You just need more insulin. And that results in what the Americans called over-basalization, but which I actually call over-insulinization, which is we're using more insulin than physiology dictates. And that drives its own concerns. Okay, so if you're needing more than 0.5 units per kilo per day as basal, and because we tend to talk about 50-50 as the optimal basal to bolus regimen, so that's half a unit in basal, half a unit of your weight in your bolus insulin, your prandial insulin, so more than a unit per kilo per day in total, then you should be starting to ask yourself, why are we needing this extra amount? Because physiologically, I've replaced your requirements. There is something else we're not addressing. Think about hypoglycemia, because hypoglycemia will trigger your body to make and release glucose. And that will cause a glucose spike in the bloodstream. So if there's erratic glucose profiles, then they may have hypoglycemia that they may or may not be aware of, particularly at night time. But certainly over-basalization or over-insulinization should always prompt a re-evaluation. So what can I do if their glucose is not at target and I've given the person their weight in insulin already and I'm not to target? Well, this is where the newer agents come in. And I guess this is where, instead of a stepwise approach, there's a lot of argument now that we should be using them in combination and earlier. So this is a study looking at dapagliflozin added to insulin. So you can see there were 3 doses of dapagliflozin used in this study. Don't worry too much about them. But the other one is placebo. So the very top line is the need to, what is the risk of, what's the probability of up titrating your insulin because of failure to respond? And you can see that by adding dapagliflozin, people did not need as much insulin over that 48-week period. And the higher the dose, the slightly the lower reduction, although there's laws of diminishing return. But certainly you can add an SGLT2 to insulin therapy, and the PBS allows that. And particularly if you've got kidney disease or heart failure, that's one way to help improve glycemic control without additional insulin. Probably for most of our obese patients who don't have a indicator for SGLT2, then GLP-1. So this is a systematic review, not a meta-analysis, but a systematic review looking at different studies where they've added on a GLP-1 to insulin or vice versa. And basically you could see that compared to baseline, the combination meant that there was less body weight gain, there was improvement in HbA1c, and the insulin dose reduction for the majority is reduced. That bottom graph is worth looking at just a little bit longer, because you can see that depending on the population, the insulin dose dramatically improved in this particular, in the red trial, whereas in some other trials it remains kind of flat. And so again, it depends on your population if you're going to get a good response, but certainly for the obese population, a GLP-1 is one way to do it. And that is because the GLP-1 needs beta cells for its glycemic lowering effect, but it doesn't need beta cells for its appetite suppressing effects, which is a central effect. And it's debatable, but it probably does work mainly via insulin on the liver, but there may be some insulin independent pathways in the liver for its effect on on the function of the liver in terms of glucose release and storage. So you could add a GLP-1 to the insulin therapy for patients who aren't at target. In fact, you can use all three because they work in completely different mechanisms for glycemic control. The difficulty with using all three in Australia is that the PBS does not allow the triple combination, and it probably never will until we have a company that makes both an SGLT2 and a GLP-1, because the companies apply for PBS listing, not the PBS, and no company is going to apply for some other companies' products. But we get around that in our clinics because the cost of SGLT2s have been coming down. There's a lot of competition. And in fact, if you're not on a healthcare card or a special subsidy, you don't actually save any money through the PBS if you use empagliflozin at 12.5 milligrams. That's one way to get around it. Just going to talk a little bit about diet, and we'll come back to Mrs. M. So as we said, she's at this point in time, and this is a point where a lot of referrals will come to us, mainly with the aim for insulin initiation. We get all our patients to do a food diary for 3 days. That's a doable time period for them. So we just say 3 days before you come back, can you record what you eat and record your sugar readings? And that's very helpful because, as I say, you want to know if failure is because of excess carbohydrate intake or whether failure is because of beta cell failure or some other factors. And this is also where you might pick up hypoglycemia because otherwise people aren't monitoring on a routine basis if they're just on oral agents. So her diet, she writes she had 3 Weet-Bix and a cup of coffee in the morning. She wakes up with a sugar of 12. She rises a tiny little bit after breakfast. She has a salad and a sandwich for lunch. She has a donut for afternoon tea that day, and then she has meat and potatoes with a sugar of 15 when she goes to bed. So at this point, I normally ask people what they think of the diet. But overall, this is not a particularly excessive diet if it is truthful. I always say if it's truthful because it's always worth making sure that the diet fits the person in front of you. And you can see that the donut does escalate her glucose up to the top, but basically she has a pretty flat profile. So she does make enough insulin to prevent a big prandial rise, but the problem is that she's generally running in the low to mid-teens all day long. Can I guess an A1C? Well, you can, and in some parts of the world, they'll actually give you an estimated average glucose, just like blood tests will give you an estimated glomerular filtration rate. This is an old study now, but it's still the best and only study correlating HbA1c to glucose, because patients are pricking their fingers, but we're talking to them in HbA1c terms, and sometimes they get confused between blood glucose of 7 and HbA1c of 7%, or vice versa. And what this study shows is that there's a pretty linear correlation for average glucose and A1Cs. There is a little bit of a spread depending on individuals, but pretty straight line. And that formula is actually the formula that will allow you to estimate an average glucose. I do this in my head because I drop the 9. So when I'm talking to patients, I just work out the HbA1c in percentage and I multiply it by 1.5 and I subtract 2.5 off that, and I can kind of remember that. But you can, there are calculators that will allow you to tell them what their estimated glucose is. This is also the formula that closed hybrid loop systems use when they give you an estimated HbA1c based on the glucose profile. And for those of you who've been looking at that, you'll see how closely correlated for the majority of people. that formula actually is. So it's very good. And because it doesn't need you to wait 3 months, you can actually see the expected projection for HbA1c earlier than actually changes at the hemoglobin level. So this is a good little table to put around your desk somewhere to help. And I've got one in front of my desk when I talk to patients so that I can talk to them in the language they understand, which is if your HbA1c is 86 millimoles per mole or 10%, your average glucose is about 13 to 14. You need an average glucose of about 7 to 8 to be at target. And that's why the recommendations for 5 to 7 fasting and no more than 10 after meals if we're going to achieve 7%. Be a bit cautious though, because ADAG, that study also showed us that it varies. So depending on people, an average glucose of 12 can either be HbA1c of 8 or 11%, depending on the person. And that's helpful because all our complication data was based on HbA1c, not on average glucose. And so, you know, the question is, why do some people glycosylate more than others? And that's a much bigger lecture to go into. But A1C is not, but glucose triggering is not the only thing to be concerned by. You do need to take into account the A1C, which gives you an idea of their glycosylation risk. So for Mrs. M, GLP-1 or insulin, would the GLP-1 achieve target glycemia? So hopefully you will realise that at 9.5%, she'll get down to 8% on average. So unless she's a super responder, she probably won't achieve target. And I want her to achieve target because she doesn't have complications at this stage. She's only 60 and I expect her to live long enough to develop complications if I don't address it. So she's probably not going to achieve target. So she probably will require insulin. And if I'm going to pick an insulin, which insulin will I use? What's my starting dose? How do I titrate? And out of the orals that she's on, which one do you keep and which one do you stop? So it's always worth remembering which oral hypoglycemic agents require your beta cells to work. Because if we have decided that she can't make enough insulin of her own now, that this is not a dietary problem, she just can't make adequate insulin even for a healthy diet, then the oral hypoglycemics that work via her beta cells are also not going to be effective because she just can't maximize it. So DPP4s, similar to GLP-1s, but they don't have the same effect on appetite. Their main glucose effect is through the beta cells. Sulfonylureas are clearly through the beta cells. So if I'm starting insulin, I need to look at the dosing of my sulfonylurea. And I could continue with a DPP4, but it probably isn't adding very much at this point in time. I could use other non-beta cell oral agents. So you could use acarbose, particularly if their diet's poor and they really don't want to change their diet. It will work, but generally people will stop the acarbose because a high carbohydrate diet on acarbose is an unpleasant lifestyle choice. Let's put it that way. Metformin does not require the beta cells to be functional because it's an insulin sensitizer. So we tend to keep metformin going when we start insulin. SGLT2 inhibitors, they work on the kidneys. So again, they're not reliant on the beta cells. And we've shown you data, so you could keep that going. And the GLP-1, we could keep going. And TZDs, we don't use very much anymore. And I suspect no one's prescribed one in the recent years. They're also non-beta cell dependent, but they do cause fluid retention, and that's magnified with insulin. So they are, if you're going to use them together, you've got to be very cautious about fluid retention. And then there's a few other problems with TZDs that people know about. think we come back to Mrs. DM, but I guess, you know, the answer for Mrs. DM is that in today's evidence, she should go on a GLP-1, but she will require some basal insulin, because we saw that she doesn't have a prandial rise, and we saw that her diet is generally good. She doesn't need an SGLT2 inhibitor at this stage because she doesn't have a complication that will benefit from an SGLT2 inhibitor, and she runs the risk of thrush and Candida and things like that, as well as DKA when her diabetes is not under control and she's not able to make enough insulin. So GLP-1 and basal insulin is the way to go. We'll probably come back to her with the dosing. Okay, case 2. This is Don. He's 55. He's had diabetes for 18 years. Unlike Mrs. DM, he has hypertension, sleep apnea, and he does have stage 2 chronic kidney disease. He's got a good GP who has put him on an SGLT2 inhibitor, as well as metformin and a sulfonylurea. And he comes to see you because he drives a bus. And as you all are aware, commercial drivers need clearance. His HbA1c is 97 or 11%. So clearly not at target. This is his diet. He has cornflakes and a banana bread and a milkshake for breakfast. He grabs a sandwich or a burger for lunch. And he has his meat pie and bread roll in the evenings. You can see the effect of the banana bread in the milkshake. His sugars go from 13 to 21. By lunchtime, that's reduced a little bit back to 17, but with the cookie and the 6 foot long, sorry, the 1 foot Subway, his sugars go back up to 22. And again, it drops back by the time he gets to dinner, and then he has a rise at dinner time, but smaller with his meat pie. So the point about Don is, you know, this is someone where they may require insulin therapy, but their diet is playing a big role in why they're not at their glycemic target. So, you know, we would be better at spending time talking and addressing diet before we jump into insulin straight away. If we aim for glucose control with that diet, he will gain weight. And he will gain it ongoing because we allow him to store the extra calories. So it's very important that he improves his diet. If he does improve his diet, but his profile stays the same, then which insulin would use? Well, then as I said, you look at the profile and you say, well, there's a prandial rise. We say anything above 2 millimoles per litre after a meal is a prandial rise, and you think about adding on a prandial insulin, or you think about cutting back the carbohydrate in the meal if you're trying to avoid extra insulin. Lots of options for Don. We might come back. Case 3, Deb, she's 48. She's had diabetes for 8 years. She's already at 72 millimoles per mole. She feels tired after meals. She can't get through her work. She's very frustrated. And you can see this is her diet. So she has 3 wheat bix with a glass of milk in the morning. She has an orange for morning tea. She has salad on a multigrain bread, coffee without sugar for lunch, and then she has meat and potatoes at dinner time. So again, the questions arise. She's on triple agents. She's not at target. What insulin will we use? What's the starting dose? What orals do you keep? How often would you titrate? Ron is 68. He's got a HbA1c of 7.7%. He's on large doses of insulin, so keeping in mind a unit per kilo per day. He's on 100 of basal, so he needs to weigh 200 to make that physiological. Metformin and sulfonylurea. His wife says that on some nights he gets quite sweaty a bit restless in bed. And he gives you this glucose profile: 5.2, 7.3, 8, 11. We don't know what he has for dinner, and before bed 12.7. So this is where it's helpful to know the estimated average glucose, because you look at that, you look at the HbA1c and you go, they don't quite match. So there's an issue there. And it could be that he's fabricated the food diary. That has occurred. But with CGM, we can usually find those people out now. But this is one that you start to worry about nocturnal hypos, because he has very large doses of basal insulin, and sweating at night, nightmares at night, are one of the signs of nocturnal hypoglycemia. And in fact, on day 2, you can see that actually he does have a 3.5. It's not unusual to get food diaries with missing information, but we still get good data out of it. So this is talking about optimizing basal insulin doses. So as I said, 0.5 units per kilo is maximal basal insulin for physiological replacement for most people. And in the Origin trial, it was 0.3 units per kilo, 0.3 to 0.4 units per kilo. So what's actually happening with Ron is that he's kind of aware that he doesn't get the sweats if he eats. So he tries to keep his sugars up. And this we see quite frequently as well, which is people say, I won't go to bed with the sugar less than 10 because I know I'm going to have a hypo. And again, we don't want to encourage that, because we don't want to drive weight gain. And really what we want to do is reduce the insulin doses. It's worth looking at pre-bed and the next morning's glucose, because if you have too much basal insulin, you're going to drop by more than 3. So if you go from 20 to 15, you've got more than enough basal insulin. You got away with it because you went to bed with a sugar of 20, but if you went to sugar with a bed of 8, then you're going to have a hypo. So we look at that pre-bed morning insulin, and we can see whether we have enough basal, which should just keep us steady, or whether we've got too much basal and it's dropping us. So it's worth reviewing that when you're thinking about, have I given too much insulin? If it's rising steeply between bedtime and the morning, then either they've got nocturnal eating behaviours, there's a risk that they've got nocturnal hypoglycemia, and we get them to wake up and check their sugars for us, or we give them a CGM to see if we can pick up a nocturnal hypoglycemic event, or we haven't given them enough insulin to suppress the liver, and this is where GLP-1s do. Actually adding that to your basal is helpful, because they, as I said, it may have actions separate to the insulin. I say may have because it's still debated whether it's just the extra insulin it releases. It could be a dawn phenomenon, or it could be that the basal insulin is wearing off, and that's where switching to a more concentrated insulin or a longer acting insulin, or splitting, giving them 2 doses may help address that question. I'm going to skip past that one so we won't run too long, except that this one was put up because this is a school teacher who basically works very hard on her diabetes and has a very healthy diet overall, weighs everything out and is frustrated. And it's just an example to point out that, not all type 2s is all dietary. Some of it is actually beta cell failure. And particularly if you've got type 2 diabetes over the age of 70 to 75, the pancreatic autopsies and histology shows us the beta cell loss in that age group. And so for some people, it's not about the diet. It's actually they really do have beta cell failure. They behave more like type 1 and they need insulin therapy. Okay, And that's what we expect, which we know that it's the longer you live, the less beta cells you have. And if you have type 2 diabetes, you're already running short of beta cells in the first place. So, 15 to 20 years down the track is the natural progression onto insulin. But we're fortunate now because we have other agents that can also assist, that actually also helps with the mortality from kidney disease and heart disease. It's always helpful if you can prevent big spikes, because although our insulins have improved, they still aren't instantaneous, which means that if you have a very large amount of carbs in one go, then no insulin we've got at the moment administered subcut is going to work fast enough to prevent that spike. And that's why we still talk about, spreading out carbohydrates out through the day, so we don't get big spikes, which in itself may be causing some of the complications. I put in Steve here to talk about decompensated diabetes. And sometimes this is their first presentation. So Steve comes in, he's got actually symptomatic hypoglycemia. He's got a strong family history of diabetes and he's overweight. His BMI is 38. He's been desperately trying to lose weight, and so he reports a pretty good diet. He's got a random glucose of 22. He doesn't have ketones, and he's already on metformin. What do you do next? So hopefully by now you remember that for this indication, he should be started on insulin. So decompensated type 2 diabetes, always think about type 1, particularly if they're young. So anyone under the age of 40, even when they're obese, I have a low threshold for screening them for type 1 diabetes, because having type 1 does not protect you from obesity in modern environment. It does when you don't have the insulin available, because you'll get the catabolism. But a lot of type 1s will be obese when they get their autoimmune process. Always think about secondary causes, particularly if it's a rapid deterioration. And we're really appreciating pancreatic cancer as a cause for that now. So if you've got someone who's been going along quite well, 6-7%, and then suddenly they're at 10%, and it's not because they've got depression and they started eating all the wrong food, or COVID lockdown and they haven't exercised and they've binged out on chips, you should think about screening them for pancreatic cancer. Rarer causes, Cushing's and acromegaly, we still diagnose them in our diabetes clinic because they've been referred for diabetes. But again, that's just keeping your mind open to the idea that there are other types of diabetes and you could develop. But regardless, when they've got symptomatic hypoglycemia, we start them on insulin whilst we're trying to sort it out. We do not use SGLT2 inhibitors in decompensated diabetes because we run the risk of diabetic ketoacidosis, and there's enough warnings put out there now that I don't think you can legally defend that position. Today, if someone develops severe ketoacidosis and has a consequence of that, without covering them with insulin first. So just to summarize, so with insulin therapy, you've got a range of different insulin types you could use. You're basically trying to pick the insulin profile that matches your patient's glucose profile in the most simplified form you can, that's acceptable to them. And that means that sometimes we don't get as great control, but we might give them a once-a-day Ryzodeg because that gets them started, and we might introduce a second dose later. If we're a very motivated person, we might start them on Basal-bolus like we do our type 1 patients, and we educate them depending on their interest and their motivation. We always review their diets when we're starting insulin therapy to make sure that we're not just dealing with excessive carbohydrate intake. If there's no significant pre to post meal, so flat profile like Mrs. DM, you'll get away with just a basal insulin. If you've got a prandial rise as well as fasting hypoglycemia, then you're going to need basal-bolus, or you could use pre-mixed therapy if you're trying to reduce injection. I tend to find that most people end up on basal-bolus because they'll come back to me and they've been doing their food diary and they're frustrated because they can't fix their glucose with pre-mixed insulin. And once you get past the burden of putting a needle and they realize it doesn't hurt, that's not the drama that they're quite happy to do 4 injections a day or 3 injections a day for the extra control. And certainly, all of this is on our health pathways. But I was going to say, but certainly, like I said, if you can get away with a simpler regimen, that's the one that you'd want. Health pathways has the data, so we basically recommend you start at half their weight, which means that the basal insulin is about 0.2 units or 0.25 units per kilo per day, and you'll give the same dose for the meals, and you split that over 3 meals, so it works out around 0.1 unit per kilo per meal. But again, you should look at the profile because not every meal needs it. Some people have carb-heavy breakfast and almost no carbs at dinner, and other people don't have breakfast and eat all their carbs at dinner. So you're trying to match your patient's requirements with the tools you've got. If you're using pre-mixed insulin, then it's a 0.2 units per kilo per meal, and we generally do it twice a day because otherwise the ratios result in stacking of basal insulin. Because of all the variability with post profiles, if you are going to rely on insulin to make a difference, then when you're titrating it, you need to adjust the dose by at least 10%, because otherwise the variability could just be chance or the day or a whole host of other things. So we recommend titrating by a minimum of 10% if you're going to change a dose, which means that if I'm on 60 units, then the next dose change is 6 units. So it doesn't make much sense to go from 60 to 62. It will take you a very long time to get to target. We've got, as I said, it's all on health pathways to help you adjust as well as to give you starting doses. And there's actually an app which we developed for junior doctors in hospital because a lot of patients need to come off their orals during the time they're in hospital, and using physiological principles. The app is called Insulin. You can download it. It's free. It basically puts the formulas onto your phone so that you could quickly open it up, plug in the patient's age, kidney function, and it'll give you a recommended starting dose. It gives you a basal bolus regimen because it's a hospital app, but you can use that to then convert to your pre-mixed if you like, or look it up on health pathways. The correction factor is really for those who are motivated and able to do simple mathematics. And that's, again, to try to get people to understand, well, when my sugar's 15, how much extra insulin do I need to give? And again, these rules come out of type 1 populations with normal insulin sensitivity. But basically, assuming normal insulin sensitivity, then the correction factor is what we call the 100 rules. So the 100 divided by the total daily dose. That's basal and bolus together, assuming a normal diet. Okay, and that means that if you're needing 50 units a day, then 100 divided by 50 is 2. So 1 unit should drop their sugars by 2, and they can aim for the target. As I said, we teach this to type 1 patients. We teach it to some type 2 patients. There are apps that will do this. So a lot of type 2 now are moving into using apps to help them adjust their insulin. So they don't need to know the rules. They just need the app to be programmed, and then, you know, the app will tell them how much insulin to give. And that works quite well for a lot of them. And that's where having an educator is helpful. And that's where Michelle's team, as well as up here, Sandra's team at Tamworth Hospital, can also help. What about nursing home patients? Now, we get quite a few referral for nursing home patients. They're often on sliding scale insulin, and we get asked to be involved because it doesn't seem to work. But that's not unexpected, because we're always responding to a retrospective event when we use sliding scale, and we're not thinking about what is going to happen in the future over the next few hours with that sugar. We're trying to respond to something that caused the sugar to get to where it was now. But insulin is a prospectively acting drug. So this case is really to say, if you've got a patient in a nursing home, then nurses should be able to manage a basal-bolus therapy, and it actually gives them better control. And you can write that as the booster as your sliding scale, but we'd recommend trying to give regular insulin for the meals that contains the carbs, because then you don't need as much correction, and it's occurring at the right time, which is I'm giving it as the sugar is rising with the meal, rather than giving it after the sugar has risen, but now the sugar is in decline, and now is when I give my insulin, and that's when I get my hypo late. So if you can see the rise in the meals, you can give a small dose to prevent that being a big rise, and they can still use the booster insulin to correct for any inaccuracies in the carbohydrate counting. Going to quickly skip through hypoglycemia, because this is what limits insulin therapy. Hypoglycemia will cause complications in the long term, in the medium to long term, that results in significant morbidity and then death. But hypoglycemia just needs to occur once, be very severe, and your death could be instantaneous. So we really don't want hypoglycemia, and in fact we spend more time working on that before we address hypoglycemia. So it's important that we don't cause hypoglycemia, and that's why starting at those physiological replacement is safe, because if they do make their own insulin, they will down-regulate, and we're not giving them more than physiological replacement. So they shouldn't get hypoglycemia from just physiological. But if you start at what you might end up at, then they're much higher risk. And that's also why we try not to treat diets with insulin if they've got very large carbohydrate intakes, because when they don't have their large carbohydrate intake, this is what the risk that they run. So it's important for hypoglycemia to recognize what it is. Symptoms occur at different times for different people. If they've been running very high for a very long time, then they may get symptoms even when their sugars are still in the normal range, because their body thinks that this is hypoglycemia. But we don't want them to overtreat that, because we want their body to get used to normal range glucose. But certainly if they're getting symptoms and their sugar is less than 4, then that's officially a hypoglycemic event. They need to know the rules around driving, which is that if you are on insulin, you must check your sugar reading, irrespective of whether you think you're well or you think you know what your sugar is. You need to test to make sure that it is in the normal range. The RMS is much more interested in hypos than they are in hypers, because decision making is affected when your sugar is low, but you have to be pretty high to affect decision making. So they have a little mnemonic, which is above 5 to drive, and that's to give people a little bit of a buffer, because if you start driving at 4.5, and you're dropping, then you could actually go into a hypo whilst driving. So if it's above 5, they've got a whole millimole to drop before they sugar is less than 4. For most people, you don't get neuroglycopenia until you're under 3 or 2.5. So there is a buffer. There is a rule of 15 that we teach patients, which is if you test and your sugar is less than 4, then you're going to take 15 grams of sugar straight away. And that's straight sugar, not a complex carbohydrate that needs digestion. Then you're going to recheck after 15 minutes. And if you're still below 4, you repeat that first step until you get to above 4. If you're above 4, then step 2 is you need 15 grams of a complex carbohydrate. And that's because if the insulin has caused a hypoglycemia, then we know that the insulin is going to work depending on which insulin is available at the time. If it's a quick insulin, it's a 3 to 4 hour window. If it's due to too much basal insulin, you could be at risk for the next 24 hours. So you need something longer acting to get you through to prevent you going straight back into a hypoglycemic event. And that's a complex carbohydrate, something that's a bit slower to break down. Severe hypoglycemia. So this is where patients aren't able to neurologically swallow safely. Then you can't give them oral glucose, and this is where you might give them glucagon as a rescue. We don't use glucagon whilst they're conscious and able to take things orally, because glucagon requires their body to release their glucose store. And so if they have a hypoglycemia a few hours after, then the glucagon may not be as effective the second time. It's also a vasoconstrictor, which can be a concern if you've got vascular disease. But glucagon is important for people with hyper-unawareness. They shouldn't be driving if they're needing to use glucagon. If it's recurrent, and that's, you know, we say once or twice a month is the most for a tightly controlled diabetic, then you need to really look at what's the trigger, why is this occurring, why are things not matching? And it could be an understanding of patients, which is they don't understand their insulin profile, they're injecting their quick-acting insulin too far in advance, they're not having carbohydrates with their meals, their injection site might be an issue, and that's where it's worth looking at their needle length and where they're putting their insulin, or their mixing technique, particularly if they're using a cloudy insulin and they're not mixing it, which means they're not really giving 70% long-acting, they might be giving 100% short-acting, and it varies depending on the mix of the individual doses. Always think about celiac disease if you've got type 1 diabetes. And if you are getting hypoglycemia, even if there is hyperglycemia in the picture, we reduce the insulin dose until we can resolve the hypoglycemia and before we tackle hyperglycemia. We've got time to tackle hyperglycemia. Sick day management is generally easier for type 2 diabetics, but by the time you get to needing insulin, and particularly in older type 2 diabetics, think of them as potentially behaving like a type 1. So when I'm sick, I need more insulin because I need to make more ATP for my immune processes. If my glucose is high, then I can give that insulin without having to take extra glucose. But if my glucose is not high, then I'm going to have some glucose with the insulin. Ketone monitoring is recommended, particularly if your patient is on SGLT2 inhibitors when they're sick. We stop metformin, we stop the SGLT2 inhibitors because of the DKA risk, we stop metformin because of the lactic acidosis risk. And like I said, it's always worth thinking about because we have so many type 2s now who are living into their 80s and 90s. And a third of our DKAs are now in type 2 diabetic patients in hospital. I won't talk about carbohydrate counting except to say that if you've got a motivated type 2 diabetic and they're keen to learn, dietitians are very helpful. There are apps which will help people to do it as well and do it more accurately. And there are apps which will calculate the insulin based on the carbohydrates, so that those formulas that I showed you earlier can be easily applied at the time that they're needed. For fasting, with insulin, technically your basal insulin shouldn't have to change. So your basal insulin dose is what's required to keep your heart and lung and temperatures going. But because we tend to cover some of our excessive dietary use with basal, you could reduce it to 80% to be in the safe side. But 80 to 100%, depending on how confident you are that this is physiological replacement and not excessive. Clearly, if you're fasting, you don't need any prandial insulin. It's tricky with Ryzodeg because you've got to remember that Ryzodeg is still working. So fasting generally isn't a big problem for the first day because of the basal requirement, if the basal requirement is correct. But if it isn't, then they're at a high risk of hypoglycemia, because even if they stop, they've still got this extra insulin working when there's no intake. So you've got to be a bit more cautious with Ryzodeg and get them to do more monitoring. With the glargines and the Toujos and the octisolin and the assemblies, you can probably keep it at roughly the 80 to 100% mark. Premixed insulin, because they've got the basal and the bolus, you don't have the choice of pulling that apart. And so we generally just say take half the dose with the amount of which means I get more insulin, prandial insulin, but I've reduced my basal insulin significantly, so I can absorb that. They generate a little.
You seem to have frozen on us, Judy. Michelle, are you there? I just thought we might be able to try and do some questions.
Hi, Jenny. Yeah, we're here. What were you going to say? Sorry.
I thought maybe we could just do some questions.
We don't actually have any questions at this stage. We did have one from a Dr. Parsons, but she's since left. But it was in regards to case study 1 and cutting back on carbohydrates and adding GLP-1. But Dr. Liu actually clarified that, and then yeah, so we don't actually have any questions.
Oh well, that's great.
Yeah, I'll just text Dr. Liu to let her know that she's frozen.
I think she might be back.
Oh, okay.
No.
No. It looks like if anyone's got any questions, now would be the time to ask.
Judy, I might just get you to leave and then rejoin. It might fix the glitch.
Will the slides be made available? Yeah, so it's just come through. The slides will be available on the PHN website. and they'll be accessible in the next day or so. Dr. Lou's just said that unfortunately she's unable to get back online, but happy to answer any questions offline if anybody has got any. So please feel free to ask any questions. We'll just hang around for another few minutes, and then we'll call it quits. Thank you.
Judy, are you up and running?
No, she said that she can see us, but she can't hear us either.
Oh,
so
okay.
Dr. Lou, I'm just going to. So there's a question.
So we've got a question. Can you please clarify how to make the change from Novomix to Rysodeg?
Judy can't hear. So it's just converting Novomix over to Rysodeg. It's just a straight swap.
But you do have to bear in mind that the Rysodeg will take a little while to kick in and start to work. So you would just do a straight swap. But Judy did recommend that you warn the patient that their blood sugars probably will run a little bit higher for that first week while the Rysodeg does kick in.
The background insulin, yeah.
Yeah.
Okay, so we don't have any more questions. So Jenny, have you got anything else you'd like to finish up with?
No, I don't think so. I think Judy was pretty well at the end of her presentation, so it sort of glitched out at the right moment. The joys of technology. Yes, you will get a link to our website in the follow-up email that you will all receive after the webinar. Don't forget to fill out the evaluation. And thank you all very much for attending. And thank you, Michelle, Jill and Judy, for giving up your very valuable time. Good night, everyone.
Pleasure. Good night. I'll get Dr. Lou to answer that.